friends. This evening, our guest speaker is none other than Dr. Dabaja Bothena. She's going to speak to us on reinventing the role of radiation in hematological malignancies. Think like a hematologist. This webinar is brought to you by Mumbai Hematologic Group. It is supported by NATCO Oncology and managed by Perfect Square. I thank Mr. James Raja Kumar and team from NATCO, Mr. Yash, Mr. Kalpesh and the team from Perfect Square, Executive Committee of Mumbai Hematologic Group. Of course, our guest speaker this evening, Dr. Dabaja Bothena, all our discussants who are themselves eminent hematologists, medical oncologists, or radiation oncologists. You participants from India for sparing your Saturday evening, and from rest of the world for sparing your morning or afternoon or even midnight. We have delegate registration today from 25 countries. Just to introduce tomorrow morning webinar, we have Dr. Pranta Chakrabarty from Kolkata speaking to us at 11:30 a.m. on design thinking and innovation in healthcare, time to give it a thought. Our discussants this evening are very important personalities from various parts of India. We have Dr. Akanksha Garg from GCRI Ahmedabad, Dr. Amit Khurana from Surat, Dr. Chandran Nair from Malabar Cancer Center, Thalassery, Dr. Darshana Rane from Nanavati Hospital, Mumbai, Dr. Deepankar Bhattacharya from Medanta Hospital, Lucknow, Dr. Deepali Borade from Apollo Hospitals, Navi Mumbai, Dr. Deepanjan Halda from Jupiter Hospital, Mumbai, Dr. Nagraj Hulgal from Nanavati Hospital, Vile Parla, Mumbai, Dr. Nehal Khanna from Tata Memorial Hospital, Mumbai, Dr. Nishad Dhakate from HCG, NCHRI Cancer Center, Nagpur, Dr. Rajiv De from Narayana Super Speciality Hospital, and of course NRS Medical College, Kolkata, Dr. Shyam Agrawal from Navodaya Cancer Hospital Research Center, Bhopal, Dr. Sunit Lokwani from Shalby Hospital, Jabalpur, Lieutenant General Colonel Velu Nair, Group Head and Chief Consultant, Comprehensive Blood and Cancer Centers, Ahmedabad. Now it's time to introduce our guest speaker of the day. She requires no introduction. This must be almost 5th or 6th time she's speaking to us. She was with us in Mumbai for one of the major events a couple of years ago. And during the pandemic, she's, as I said, she's really become a friend. Every 3 to 4 months, we have bothered her with one or the other subject in her specialty, and she has obliged us. She is Professor and Section Chief of Hematology, Department of Radiation Oncology, University of Texas, MD Anderson Cancer, Director of Research, International Lymphoma Radiation Oncology Group, Houston, Texas. She received her medical doctorate at the Lebanese University. She completed her clinical residencies at the American University of Beirut and the University of Texas, MD Anderson Cancer Center, Houston. She began her career at MD Anderson following her residency in 2006 and has progressed from assistant professor to professor and then section chief of the hematology section of radiation oncology. Her primary clinical goal is patient care, with an emphasis on maintaining and improving cure rate in patients with lymphoma while decreasing the short and long-term side effects of treatment. She is intensively involved in clinical trials to investigate multiple strategies to deliver better treatment options for lymphoma patients with the goal of minimizing long-term side effects on patients treated for mediastinal lymphomas, which remains a great clinical challenge. I invite her to deliver her lecture this evening on reinventing the role of radiation in hematological malignancies. Think like a hematologist. So over to me.
Thank you so much. Every time you invite me, it's really a pleasure to be among you. And as I told my colleagues, it's really inspiring the questions that I get and the discussion that I get with my colleagues in your center and around from the centers around India. So it is a mutual pleasure and also sharing of information. I'm gonna ask for control request 1 second, and once I get it, I can, yes. So now we can decide. So today what I wanted to do is to show you how we evolved in the realm of radiation oncology. And it happens in learning from history, of learning from the past. Obviously, we do not use the radiation as a consolidation like we did in the past. We know that we used it for Hodgkin, diffuse large B-cell lymphoma. We actually evolved from using it as a major contributor to the cure to just a minimal contributor to the cure. And the evolvement that happened is you move from very large sites to small sites to decrease the toxicity based on so many papers that were published in the past. You are all aware of, and that's what started the debate whether we really need radiation or not. So at that moment, the radiation oncologist needed to do something. And thankfully, it happened at a time where technology was booming, and you could see it in the simple way of how we communicating today, which was not possible to any of us 20 years ago, and just mirror that to understand how the technology helped radiation oncologists to achieve a lot. So therefore, you will see that there is a lot of changes that has been applied. But the most important, which I'm gonna get to it towards the end of my lecture, is how we moved in hematological malignancies. It only applies to hematological malignancies at this point, from a cell killing approach to an immunogenic cell death. And I will show you a few examples, including a leukemia, which was something that we never thought about. This is a slide that I borrowed from Dr. Andreas Enger, the head of the German Hodgkin study group, where it shows how we moved from using in the 60s what we used to refer to as total lymphoid irradiation, and the purple is the field of radiation that used to cover a big part of the heart, including the major coronary vessels, the spleen, the para-aortic nodes, all the way down. And if this was a female, you could see how half of the breasts were covered with a dose that was almost 40 to 50 gray. And that could explain all the side effects we ended up with. And as we progressed over time to the modern day, now we know that chemotherapy can take care of the majority of microscopic disease all around the body, while radiation is only needed for the area where the patient presented with disease. And to avoid the toxicity, we have a huge number of techniques and technology that we use to help us deliver the treatment without causing any toxicity. The typical, what we called ISRT, which is the new terminology that we've been using now for almost a decade, as opposed to involved field, looks like this. If you have a patient that presented with an original mass that you can see it right there, whether Hodgkin, primary mediastinal lymphoma, or even lymphoblastic lymphoma, once they get the chemotherapy and the tumor regressed to nothing, that the only thing you need to chase is where the mass used to sit. That's the site. Therefore, the word involved site. And because lymphoma in general, and as opposed to adenocarcinoma or squamous cell carcinoma, it does not have fingers to invade the neighboring structures. Therefore, whenever you chase the site, you do not chase it as it was expanding, because you have to think about it as a balloon that deflated, and you only chase the stem of that particular balloon. And that's how you end up with a field that looks like this. Note that the red line is the full dose of radiation The purple line is the least amount of radiation. And if you look at it in this area, you could see that the left ventricle is completely out of the field. The common coronary vessel just have a tiny bit of it in the low dose, but none of it for the rest of its path in the high dose. And in a female, as you can see here again, the low dose is nowhere near the breasts. So basically what I'm showing you today is our goal and the end result of what a radiation oncologist should think about whenever you're treating these cases. For the cases where you cannot achieve this, you can easily say that I do not want to treat, or you can make it your priority that I want to avoid the heart and the breast and the lung at the expense of making my dose lower to the target, because the more we lower the dose in hematology, the more we're realizing that a higher dose is not needed. I'm going to take this particular case that I'm going to show you where a patient came with multiple relapses, just to tell you that whenever a radiation oncologist needs to treat these cases, they have to be very careful about the kind of chemotherapy that these patients got. Take, for example, a Hodgkin lymphoma patient that presented with this extensive disease, eventually received a full course of ABVD with bleomycin dropped the last 2 cycles. The patient ended up with a Duvel 5 at the end, which you could see it here. That's August 3rd. We waited on the patient for a bit before proceeding with any further treatment or decision. And the Duvel score or the PET activity became really concerning, and a biopsy was done and it showed that the patient is in relapse. Then the patient ended up with a salvage chemotherapy that got him into remission, followed by autologous transplant with a congestive heart failure at the time and an EF that dropped. So then what do I have right now when the patient is coming to receive their radiation? I have a patient that got bleomycin, gemcitabine, busulfan, melphalan, all of the lung toxic treatment. And I got a patient that got adriamycin, had a drop in his heart. And if this was a female, I obviously has to take care of this, which is not the case here. So then how do I plan this case? The end result of my planning should look something like this. I'm going to go after the earlier disease that responded to treatment with a regular dose of the 3rd gray, and boost the area where the patient came with a relapse with a bit more. In the past, we used to go up to 40, 45 gray, but nowadays we barely go to 36 gray. And then I want to avoid the coronary vessels, I want to avoid the lung and the left ventricle for the reasons that I just mentioned to you. How do I avoid the breast? We developed this board that has been adopted by many institutions around the nation, where you elevate the patient and you drop the breast from something like this, even if a woman has a breast implant, to something like that. And what you're trying to do is, if this is the mediastinum here on a regular CT while the patient is flat, and the breast, as you can see, they are full size at this level, then when you put them on the board, you actually drop the breast away from the field. And that's how you end up with the picture that I showed you, avoiding the breast. We use deep inspiration breath hold, has multiple values, including if you think I'm targeting an area and saving the others, then the ratio between the target and what you're trying to save, you change it to your favor. Again, you move the heart away from your field just by taking a deep breath and holding it in your chest, and that moves the heart away. It makes your target, which is the mediastinum in this case, even smaller compared to free breathing that you see here, makes the lungs almost double the size compared to free breathing that you see here, moves the heart away from your treatment compared to if you use free breathing here. 100% of our patients, whenever we want to use chest irradiation, we use it with breath hold. And nowadays, we even use it for abdominal, even if it's something lower in the abdomen, because that keeps everything at a static place, and we don't have to make the field bigger to chase it while moving up and down. Now, we talked about technology that luckily it came at the same time where we wanted to shrink our fields. And that technology is a computer system where you tell it where you want to target, where you want to avoid, and it comes and turns around the patient with windows that opens and close. And I'm going to show you something that will be helpful to you to see. And what it does, it tailor or paint the dose exactly where you need to paint it. There are multiple solutions for that computer program that has been invented, some by us, like the butterfly technique, the rainbow technique, and some by our Italian friends, where all of them, what they meant to do is teach the computer where you deliver a treatment that would go after the target while avoiding the toxicity. Now, this is a foreign concept to even radiation oncologists, because radiation oncologists in general, they don't deal with hematological malignancies. They deal with lung cancer, prostate cancer, head and neck cancer, where when you give the dose, you always tell the patient, I have to give you a very high dose, sometimes 3 times the dose that we use in hematology. You're going to end up with side effects. I'm sorry that this is happening, but deal with it. In hematological malignancy is completely the opposite. My number one priority is always the side effects, because I'm just trying to help chemotherapy. I am not the main person who's curing these patients. This is the end result that I want to see. I can remind you again that the red line is the full dose of radiation, and the green or forest line is the lowest dose of radiation. As you can see, that red line encompasses the mediastinum, avoid completely the breast. Even with the lowest dose, it's not nowhere near the breast, nowhere near the left coronary vessel, or the left ventricle. And the way you do it is you depend on the computer to move the dose, but you also keep, it's like you're trying to use a software that will run automatically, but at the same time interfering with it, because you know exactly what you want to do. I give you an example for the radiation oncologist in the audience. If I know that I want the heart to go to 5 gray, I will tell the computer, I will not allow more than 3 gray. So you push it very hard to meet the 3 gray. If you're looking for the 5 gray, that's how you push to the limit, and you make sure you get what you exactly need. This is just a color display of what we're talking about. We avoided even the low dose to go to the lungs, because we said that in this particular patient, he's been exposed to bleo, bisulfan, melphalan, gemcitabine, all lung toxic. And same thing for the heart, that the patient ended up with a congestive heart failure. Now, it doesn't mean that I'm only going to use this in a case of a patient who's heavily pretreated. I will use it also for a patient after the first chemotherapy that is going to live 30, 40 years down the road. And I want to make sure that the radiation is not going to cause them any toxicity, because from the old data, we know that half of Hodgkin lymphoma patients that passed away, they passed away from the disease, but the other half, they passed away from toxicity. Not all of it radiation, but radiation was a contributor. Now, whenever you do something on the computer, you want to make sure every day that when you're delivering it the right way, including when you tell the patient to hold their breath. So we have a system at MD Anderson where the machine has a CT scan and a linear accelerator. Every single day, the patient would be laying on the table, you scan them, you put the plan that you already made on that patient. Once you scan them, the physician would look at it and make sure that it looks okay, then we'll proceed with the treatment. So that way you would confirm the accuracy of your treatment on a daily basis. Obviously, it takes a lot of time, but that's the whole idea. At the end of the day, these are the papers that I live by daily when I'm treating a mediastinal disease. I live by those parameters for the lung that are not past a certain dose should go to the lungs. And this is publications from one of my colleagues at MD Anderson, Dr. Pinnock. We also made a nomogram for those who are heavily pretreated to make sure when we're planning them, what is considered safe for the lungs not to cause pneumonitis. We also live by this pediatric data where we say that if you are a general population, which is this blue line, that's your risk for heart disease many decades down the line. The only thing closer to this, if you keep the radiation dose to the heart between 5 and 15, which we call it the mean dose. Although this is the lowest dose possible, but that's what we live by, and we make sure that this is the dose that we are going to give to those patients. I'm sure that many of you have heard about proton. It is an expensive technology. It doesn't exist everywhere in the United States. We obviously have it. And sometimes there are fashion that comes in technology that would force many physicians, whether medical oncologists or radiation oncologists, to use it. So we found, or we made these international guidelines that we published in Blood a few years back to help physicians that do not have proton to really know when to send these patients to major centers with proton. And I think that the take-home message from this very elaborate guidelines that has a lot of physics is to tell the radiation oncologist, at the end of the day, what you need to do is to avoid the toxicity with whatever technique you use. So if there is a minor difference between proton and photon, don't send the patient for them to pay an arm and a leg, sell their house to get proton, while you know if you use another technique, you will get to the same results with that technique. So that's the only thing I'm going to say about proton, is to not to think much about it if you don't have it, because you can still do the same technique if you're smart about it and you know the side effects of the chemotherapy and you have a continuous conversation with your medical oncologist without the need for proton. We published almost 25 guidelines from the International Lymphoma Radiation Oncology. All of those guidelines were meant to teach the radiation oncologists around the world two things. One, hematology is not solid tumors. You might think, well, yeah, of course, hematology is not solid tumor. But then the reality is, majority of radiation oncologists thinks of hematology as if it is solid tumors. And they think that they are so essential for the treatment that they want to still give a high dose, still go after every little thing here and there, forgetting that the chemotherapy is extremely effective and their role as a radiation oncologist is just to help. Obviously, that technology is not only helpful for the chest, it is helpful, for example, if I'm treating the pelvis, a regular radiation oncologist treating rectal cancer or GYN cancer, they never pay attention to the bone marrow. They only pay attention to the bladder, to the prostate, to the rectum. But then if I'm treating the pelvis for a hematological malignancy, number one priority is going to be the bone marrow. There is at least 25% of the marrow just in the iliac crest. And if you add the sacrum, you would end up with around 40% of the marrow in an adult residing in the pelvis. So if I'm not careful and I give a dose more than 20 gray, you would dry up the marrow and cause pancytopenia, and that would be detrimental for any chemotherapy you need to use in the future. Kidneys. If you're treating the kidneys for a stomach cancer, pancreatic cancer, you use the radiation without thinking about the kidneys or even thinking about the spleen. But we do think about the kidney, and we make sure that to avoid the kidneys at all costs, since these patients are going to see a lot of chemo and possible transplant in the future. Salivary glands, it became the easiest thing to avoid at this point. This is an example of how I'm treating both necks. Again, look at the red line and look at the very low dose, how it's skirting away from both submandibular glands and both parotid glands. So dry mouth should be something of the past these days when you're treating hematological malignancies. I like this paper. Our friends, the Japanese, published it 2 years ago, and I was extremely, actually last year, I was extremely thankful to their efforts. And what they showed is that a V5, which is the volume that get only 5 gray, that's like the lowest dose of radiation that you give, does affect the kidneys on the long run and causes kidney disease. And that was extremely important for us because, as you probably know, in the United States, you cannot use certain techniques if the insurance company would not allow you to. So that paper came to rescue us from many of the long phone calls that we have with the insurance companies about the kidneys. So what we learned so far is that we are capable of dose painting and avoiding organs at risk. We did develop specific constraints for hematological malignancies, that we should not use the solid tumors malignancies. And we also develop what we call the differential dose. Keep it in mind right now, because we're going to talk about it in a bit when we talk about transplant. So then how did we evolve from more is better, which our colleague in medical oncology passed through a period where more is better until the immunotherapy became available to us, to use biology to our benefit? And what is the future application of the microenvironment when you talk about radiation? We should learn from the past when it comes to microenvironment. And we should first and foremost learn from follicular lymphoma. A typical follicular lymphoma stage 1, stage 2 in the past used to be treated with 45 gray. Now we treat it with 24 gray. It used to be treated with what we call total lymphoid irradiation. Now this is disease, goes up and down here, and you do the same thing. You only chase the disease and treat it with only 24 gray. Now you would wonder, that is it all cell killing? And that's what we're gonna come to next, but after I show you multiple examples. Same thing we did with multiple myeloma. The role of radiation oncologists in multiple myeloma is extremely insignificant. We are equivalent to the pain medicine, basically, because you only give radiation when you have pain or risk for fracture or a nerve pain. Therefore, whenever you want to treat with the least possible dose that you can give, because you can never predict when is the next site of multiple myeloma that is going to come to hunt you. And if you take the liberty to keep your fields large and give a large dose, then you're going to end up with a bone marrow suppression that will hurt the patient on the long run, dry up the marrow on the long run. What I'm showing you here is that's what we go by. I have it in the clinic for the 6 faculties that works with me. All of them, they do hematology, to look at every time they give a treatment for a myeloma, how much marrow exists in each bone that they are treating. And as we discussed just a bit ago, sacrum around 10%, pelvis 25%. So you're almost 35% just for your pelvis. Therefore, if you're treating something there, to be super careful. And we also know that past 20 gray, you dry up the fat cells in the marrow, and the stem cells cannot survive in that area. Therefore, we run a study of over 1,700 sites where we gave them only 20 gray as opposed to 30 gray. And we found out that the risk of recurrence is only 2.6%. So we established that as of now, we're only going to use small fields and a dose of 20 gray as opposed to 30 gray in 10 fractions. The radiation oncologist in the audience, I'm sure they understand what I'm talking about. There is always a debate, what if I have a cord compression? The same thing. Even with the cord compression, we did not really find a higher risk of recurrence with these patients. So even for a cord compression, do the 20 gray. If you use the 30 gray, then you can never treat the next time next to this fields, and you would shoot yourself in the foot, basically. Now, again, what we're discussing right now, how we drop the dose at every single level, and we're gonna get from this to talk about the microenvironment. But in the meantime, as you know, the dose that we use for diffuse large B-cell lymphoma is 30 gray, and it went down from 50 to 30 gray. Part of our efforts in the International Lymphoma Radiation Oncology Group is to do trials together. So this is a prospective study that is run by our colleague, Dr. Kelsey in Duke University, where he's trying to give to 240 patients, instead of 30 gray, 20 gray, past complete remission for a diffuse large B-cell lymphoma. So far, we registered 156, and the preliminary finding that probably the future of diffuse large B-cell lymphoma is not going to be 30 gray, it will be 20 gray. I give this example all the time about this patient who allowed me to share her partial face picture everywhere, where she presented with multiple lymphoma, and she was in another hospital where they were going to do stereotactic radiosurgery, which means as if you are giving her, compared to where I gave her, something like 40 times the dose that I'm giving. While I was with her on the phone, she's a friend of one of the physicians, I realized that she has this. I told her to take it off, run as fast as she can from that hospital, went to another hospital where it's one of our satellites, gave her only 4 gray, and she is now probably 7 years past this incident, and she's still in remission. Based on that, we published our study. At the beginning, we had 50 patients of multiple lymphoma of the eye that we treated with 4 gray. Now we have 102 that we're presenting this year in ASH by Dr. Pinix, and showing the same results, which is you have more than 90% complete remission that is durable when you give only 4 gray. We also did that with multiple lymphoma of the stomach. As you know, we used 30 gray. There is no room for surgery in multiple lymphoma of the stomach, and obviously no room for chemotherapy. We only treat them with radiation. But we ran the study, we completed accrual in this prospective study of 25, and the end result is that more than 85% durable complete remission for multiple lymphoma of the stomach. But what is the key in all of those? Waiting. And you're gonna know why waiting is important in a second. Anaplastic large cell lymphoma, they look ugly. Pathologically, sometimes they look as if they have large cells. People confuse them with aggressive disease. They cause ulcers, deep ulcers. Also, you give them 4 gray, 6 gray, and you wait on them, and you can actually control it. Mantle cell lymphoma, we know right now that immunotherapy is the way to go. While I was preparing for this talk, this New England Journal of Medicine came from Dr. Michael Wang from MD Anderson, talking about the ibribinda and rituximab in untreated mantle cell lymphoma, where you can see an improvement in progression-free survival. The reason I presented this, because the mantle cell lymphoma that we know of more than 20 years ago, now we don't treat it the same way as we did before, where it was chemotherapy. We're using multiple immunotherapy. Therefore, they're gonna live longer, fail multiple times, and we're going to see them in the radiation clinic also multiple times. Therefore, we published also this in Blood Advances when actually it came out when I was in Mumbai last time in person. And what we showed is that a very low dose of radiation can take somebody with this mass in their throat to something, nothing there. Again, waiting is key. Don't start the radiation and 2-3 days or a week later say, well, it didn't budge, I need to give more. You have to be very patient. We're running a prospective protocol right now on all of these mantle cell lymphoma, and hopefully we're gonna report it soon in ASH about the benefit of an ultra low dose radiation in mantle cell lymphoma. specifically in patients that are going to present with pancytopenia, multiply treated either with chemo or with immunotherapy, and we're going to treat them with a low dose of radiation. So what we learned now, not only that we dropped the dose in follicular lymphoma, diffuse large B-cell lymphoma, LP Hodgkin, that just recently, last week, we're not going to define it anymore as a Hodgkin, which is a brilliant idea. We're going to more define it as a B-cell lymphoma. That's the most recent WHO from Dr. Campos that came. Marginal zone lymphoma with dropping the dose, mycosis fungoides, myeloma, mantle cell lymphoma. The key to all of those is that radiation does not only work by cell killing, it works by awakening the microenvironment, harnessing the T cells to our benefit. And that's how, little by little, instead of killing everything, cancer cells, you're telling the microenvironment, this is the enemy, go and take care of it. It's like you have an enemy coming to your way, your army, they're not smart, you go train them to be smarter, and then you attack the enemy, versus telling somebody to come and drop a nuclear bomb on it. That's in war terms, basically. So then we come to the immunotherapy that harness the power of T cells. And the idea I want to introduce to the medical oncologist today, so does radiation. We do harness the T cells, and that's an extremely exciting way of thinking about it. How did we learn this? We learned it from solid tumors, melanoma in particular. This is a Nature paper that came from our colleagues in University of Pennsylvania, where you can see Tregs and T cell effectors are the most important. Those Tregs, sometimes they are enslaved by the cancer cells to stop responding to the immune system, or to stop responding as they should, or doing their job as they should. When you give radiation, what happens is you increase that diversity in the repertoire, and what you want is to decrease the Tregs and increase the CD8. You add to it anti-CTLA4. You find a result which is fantastic. Then you go into another resistance. Then you add another immunotherapy, a checkpoint inhibitor. And at the very end, you see that you went from diversifying the repertoire to, even if you exhaust the CD8 to Treg ratio, you reinvigorate it to your benefit with another checkpoint inhibitor. So what we learned from that is the following. There is an intelligent way of using immunotherapy. You cannot, just like how chemotherapy used to do, throw it at the patient. You have to use it at the right timing, the right sequencing for it to work. And we also learned that radiation does also reinvigorate the T cells and decrease the T regulatory cells. Now, this concept was present for a long time, over 70 years that we knew about it in radiation, but obviously until most recently that we started incorporating it the right way. We started talking in the 70s about something called abscopal effect, which means the effect of radiation outside of the scope of where you're giving it. If you're giving it in the axilla, the effect will be in the groin. If you're giving it in the groin, the effect will be in the neck. And eventually we started adding it to immunotherapy, and that, as I said, in melanoma, and eventually we used it in hematological malignancy. So how does it work in a nutshell? You give radiation to the tumor, you kill the cells, you cause antigen to be released. These antigens, they go into the vessel by the antigen-presenting cells. They go into the lymph nodes. They transform the naive CD8 effectors into an activated CD8 effectors. They circulate in the blood, and they might go to other areas where the tumor is and do what they need to do. This is a common theme that you see with immunotherapy. And that's why we started thinking about the checkpoint inhibitors, or the anti-CD47, or of the CAR T cells. And the concept of immunogenic cell death became available to us where you irradiate the tumor, you induce an immunogenic cell death. Because of that cell death, you induce the immunity and cross-presenting and cross-priming. And that's why the word priming replaced bridging when we talk about cellular therapy right now. Because I'm not holding the tumor until you give CAR T cells or immunotherapy. I'm actually priming the tumor. That cold tumor, I'm making it hot for you. So when you bring the immunotherapy or the CAR T cell therapy, it will help you and improve it. We know that, for example, a simple example, which is the dendritic cells, that the eat me and do not eat me signal, radiation therapy can switch it on and off to our favor. Many of you know the mogamulizumab that we're trying now to run a study where we give the radiation and the mogamulizumab in AML and see if that would be helpful as a synergistic effect. There's a lot of, when you give ionizing radiation, there is a multiple immune modulatory effects. I'm basically hammering on the idea that you're promoting the cross presentation and you're increasing the CD8 effector. So I'm going to move on from this to show you that in solid tumors, there are many publications about the role of radiation with immunotherapy that you can see it here. The common theme that you see is that the dose of radiation used as opposed to solid tumor is not as high as we use in lung, prostate, bladder, stomach. It's actually way lower. Why? Because you're not interested in the cell killing, total cell killing. You're interested in a bit of cell killing and reviving the microenvironment. Do we see that in the clinic? I think last time I discussed this, but I want to get to the point that we talk about the recent studies that we're doing. I had this patient with diffuse large B-cell lymphoma. He was going to get CAR T-cell therapy. I was asked to give him radiation to this area, which is in the peripancreatic, almost going into the liver. I did. But then day 7, without me knowing, the medical oncologist asked for a PET scan for screening for a protocol. And what we found out is that the area which was here that I'm treating is gone. But then as if the whole body is hyped with the lymph nodes that are angry. We go ahead and do a biopsy thinking that the patient relapsed. And we found out that this is only a lymphoproliferative disorder or lymphoproliferation. And this is how we learned that probably we can see it in the clinic if we follow these patients. Another example, a patient that comes with extensive diffuse large B-cell lymphoma in the abdomen. You treat them with dose-adjusted REPAC, they get into remission, they fail, you treat them with R-GemOx. Then now they are being prepared for radiation, for CAR T-cell therapy. They have a relapse in all of this area. You're asked as a radiation oncologist to treat the area in the abdomen, not necessarily the one in the next to the heart, because you don't want to increase the toxicity prior to CAR T-cell therapy. I treated this patient to all of this field. PET scan was done just prior to proceeding with CAR T-cell therapy. The area where I treated is gone. Everything around it is highlighted or booming with something. The patient goes into CAR T-cell therapy, he's in remission 2 years later right now. What that tells you is that when you gave the radiation to a lower dose in particular, you actually helped the CAR T-cell and reinvigorated the CAR T-cells. We published on the role of radiation, us and Moffitt and others, and Memorial Sloan Kettering. And the common theme is you give it before and you make sure to phase it with the apheresis or the lymphodepletion in a way that you would not hurt it. And you make sure that you give a lower dose. Why the lower dose? Because as I'm giving low dose of radiation, increasing the CD8, decreasing the Tregs, when I stress the system so much, then I will start killing the T8 and increasing the Tregs, and that will work against me. And it's for that reason. Then there was another issue. Could you give radiation post-CAR T? And the idea was very scary because you don't want to give radiation and the CAR T cells that are circulating in the blood, you catch them and you kill them. This is a typical patient that presented to us, had this disease in the at L4 level. I was asked day 13 to give him treatment. Day 13, that means at the peak of the CAR T cell therapy. I gave this patient a very small field here after discussion with the head of the CAR T cell program at MD Anderson, Dr. Nela Po, and took the approval from him. Then eventually, the patient actually went into complete remission, although the patient was not showing any improvement, which means that probably we reinvigorated the T cells. Our colleague in Memorial Sloan Kettering published on BECMA, which is for multiple myeloma, same story. The patient was not responding to BECMA, had pain in the lumbar spine, treated with radiation, and eventually they followed the T cell clonality after giving the radiation, which is in yellow here. And then they started seeing that the T cell clonality actually is diversified and increasing, which led us to start at MD Anderson thinking out of the box. And now we have a study, a prospective one, where every single patient that is going to present with a failure after BECMA, that we're going to give them radiation, follow the T cell repertoire and see what is it we're doing. And if we can, when we give the radiation, maybe re-infuse them with the BECMA or the CAR T cell of any sort for multiple myeloma, and then later on reintroduce it to other diseases where we use cellular therapy. So how about prior to transplant, or how about for leukemia? I will go through leukemia very quickly, just to knowing that this is a subject that is not surviving in many aspects in many academic institutions, because I do talk to my colleagues in Memorial Sloan Kettering or in MGH, and I know that they don't use it that often. But I will show you in the next few minutes before we conclude that using it in AML as a palliative measure is what led us eventually to start looking at it as a priming effort, and a few grants that we submitted and we were successful in getting. We learned that in AML, intracranial disease is associated with inversion 16. So every time we have a patient like this, we usually treat them not with the whole brain. We just go after this area. Gum disease is monoblastic. We treat these cases and we give them a very small dose of radiation. There is no point of giving them a full course of radiation because, as I said, in myeloma, the radiation oncologist is almost like the pain medicine, and in leukemia is no different in many cases. In CNS disease, for example, we learn in AML that complex cytogenetics, more than 4 abnormalities, are associated right now with a CNS disease. But the reality is, our patients with AML, knowing now what kind of cytogenetic abnormalities they suffer from and having the immunotherapy that targets these specific cytogenetics, they're living longer to receive multiple salvage treatment and eventually get rescued by either transplant or eventually develop a CNS disease, which happens because the majority of immunotherapy that you're giving and or chemotherapy that you're given is not going to cross the blood-brain barrier. So it will be an outstanding problem that you have to deal with all the time, which is the CNS disease. And that's why we incorporate right now craniospinal irradiation prior to transplant in a patient with AML, either when they have CNS disease or when they have multiple recurrences and cytogenetic abnormalities that we know it's a matter of time before they come back with a disease there. Leukemia cutis also, we treat it with total skin irradiation. The way we apply CSI prior to transplant, as I said, if a patient has failed CNS-directed therapy and has no prospect of allogeneic transplant, we give them CSI. or as part of a conditioning prior to transplant, where we know there is an imminent risk of CNS disease. And the dose that we give is only 20 gray. We come back to the fact that hematological malignancies are extremely sensitive to radiation, and this is a blessing that you can get all the benefit with the little side effects possible. ALL, I borrowed this from Dr. Kantarjian, where it shows how the ALL in children improved, obviously thanks to Dr. Freira's effort giving combination chemotherapy, and was the first one who gave intrathecal chemotherapy. So you can see the improvement in the survival compared to the 1970s until now. But also you can see that there is novel treatments, all the available immunotherapy that you can use, to a point that now we're replacing part of the chemotherapy with immunotherapy at the beginning of the treatment to manage these patients. The end result of this, they live longer. Also, the end result of this, they relapse and are rescued, and you can rescue them. Therefore, the more they relapse, the more the CNS becomes a problem, the more the radiation oncologist has a role to play. We published in 2016 this paper. What we meant from it is, should we only do whole brain radiation or should we do craniospinal radiation? And that was like an argument that we had in the leukemia meeting with Kantarjian, and Dr. O'Brien was there. And eventually we published this paper on 163 patients. And what we found out is that if you give them a comprehensive craniospinal irradiation, you actually decrease the risk of CNS disease and improve on their progression-free survival. We are not claiming that when you give them radiation, you're going to improve the overall survival. No, we are saying that if you get the CNS under control and you go through an allogeneic transplant, you avoid the heartache of being engrafted, in complete remission post-allogeneic transplant, and then the patient would not come back with a CNS disease. Then what are you going to do? You go back to square one, although your marrow is in remission, even MRD negativity, and then you end up with a CNS disease. That's what we're saying. We also published guidelines on when to use CSI from the International Lymphoma Radiation Oncology Group, and gave people some hints on where you have a role. For example, mixed lineage leukemia, early precursor T cell, and so on and so forth, and it is used. Now, do I use proton therapy on all of them? The reality is I don't. For logistic purposes, that is not important for audience outside of the United States. But the point is, we have multiple techniques that we can use on these patients to do craniospinal irradiation, including proton. One thing that, before we jump into how we use the immunotherapy in combination with radiation, is something that is dear to my heart that I like to share all the time, which is a patient that presents with leukemia with multiple treatment, hyper-CVAD, allogeneic transplant, immunotherapy, comes with a typical picture of paralysis that looks like leptomeningeal disease. Please be careful that you suspect myelotoxicity from intrathecal treatment, which is seen on the MRI on the T2 signal as a myelopathy in the dorsal column. They have a typical symptoms of dorsal column, lack of temperature, no discriminatory effect, no proprioceptive sensation. And if you do the MRI, ask for a T2 weighted signal and look for the dorsal column. And when you suspect it, these patients, quite often, they've had a lot of intrathecal chemotherapy. Now you would wonder, why is it that chemotherapy would do this intrathecally? Quite often for ALL in particular, what we used to do is we would give the intrathecal, and sometimes you would give the high dose methotrexate at the same time or during the same day. So therefore, the folate will be, the folate pathway would be overwhelmed, and could very well be that the methotrexate has stayed in the CSF for longer than what it needs to. And then eventually also the number of times that you give intrathecal methotrexate. Our patients 30 years ago, they didn't used to live for a long time to receive. I have a patient who received 40 intrathecal methotrexate, and I hate to say it, but another patient received 50 intrathecal methotrexate. We didn't have patients in the past that will live that long to receive 50 intrathecal methotrexate every time they come with a disease in the CNS. And it is for that reason we're seeing these myelopathies. And we know for a fact that it is from the intrathecal because none of these patients had ever received radiation therapy. And in one of the cases, actually, we did an autopsy and we did see it. They did see the myelopathy right there in the dorsal column to confirm that it is demyelination. We also use it in lymphoblastic lymphoma. I know that this is not a popular option. I do advise the radiation oncologist that whenever you use it for lymphoblastic lymphoma, do not chase the pericardial effusion, do not chase the pleural effusion, because there is no point. You're only giving it to the stem where the mass came from, and you only need to give 24 gray, not 36 gray like it is mentioned in majority of guidelines. You need to use IMRT, avoid the heart, because this heart has been exposed to adriamycin at a high dose from the hyper-CVAD in these cases. So my advice is, if the radiation oncologist does not feel comfortable treating these cases while avoiding the toxicity, then you don't have to use it. But if they can use all the technology available, then I would advise for consolidation. Now, dealing with leukemia, one of our colleagues from University of Washington ran this extremely helpful experiments where he used leukemia mouse model and gave radiation with CAR T cell. These are the mice that received only radiation to the tumor. These are the one that received only CAR T cell. These are the one that received no treatment whatsoever. And these are the one that received both radiation followed by CAR T cell. And you can see that those are the only one that survived for 14 weeks. Another group from Cornell did the same thing. And I'm going to show you how those mice that received the radiation with CAR T, which is the group 3 and 5, they did the best compared to the mice that received either CAR T or radiation alone. So then what we benefit from that is to say, it must be radiation in AML, which is not necessarily an immunogenic tumor, but we're hoping to produce a systemic immunogenicity by the radiation killing the cells and eventually going to the draining lymph nodes and into the blood vessels and eventually causing a humoral or a systemic priming that when you add the checkpoint inhibitors in AML, maybe we can show that adding radiation prior to checkpoint inhibitors might be beneficial. And recently, in the most recent conferences about AML and checkpoint inhibitors, it was disappointing to give checkpoint inhibitors in AML. And we thought that that's even more exciting for us to try it with radiation. Maybe we can show that in our hypothesis that we're going to give radiation to an extramedullary AML and hopefully cause an antigen presentation, stimulate the dendritic cells migration, increase the T cell effectors, affect the T regulatory cells, and eventually cause this systemic effect. And hopefully we can come with a checkpoint inhibitors after that and see if we can change it. Our preliminary data that we found so far from Dr. Spioto's lab at MD Anderson is that we do increase the calreticulin and HGMB1, and we're seeing a signal with a certain dose of radiation. So now we are moving as part of Leukemia Sport, and we submitted a grant to the Department of Defense to further look into this, and we're very excited about this protocol. Differential dose that I talked about it before, it's time now to discuss it. Total marrow irradiation and why the differential dose is important. The total marrow irradiation, it will benefit that you would concentrate the dose in the bone and obviously avoid all the other critical organs prior to transplant. Now, what we went one step further at MD Anderson with a protocol that we also are getting a grant on to do a differential dose where you use a myeloablative dose to the bone while a priming dose to other organs like the lymphatic organs. So we would hit two birds with one stone. The way we do it is, and as compared to before, we use a very sophisticated technique that I'm going to show you in a second. That's the sophisticated technique that we use. In the past, when we use total body irradiation, it's literally an open field that will go through and through everything in the body. And then you bring a material to block the lungs physically. You put it in front of the lungs or in front of the kidneys, and that would be total body irradiation. What we're doing here, and I want to attract attention again to the red lines. These red lines are encompassing the bone. The blue lines is a dose of around 6 gray that encompass everything else, which is to a lower dose. And the way you do it is by using a very sophisticated treatment that when we do the panel, I'll show you a way of doing it. But it's a machine that will turn around the patient. And as you can see from these leaves, they open and close and open and close. Every time they see your target, they open, and every time they see a critical organs that is predefined, they close. And that's how you end up with painting the dose where you really need it. And the reason we did this because we wanted to, as part of a protocol that I will show you at MD Anderson that we are doing, we call it the V2 cells, where we take these cells from the donor, we expose it to viruses and eventually reinfuse it in the body. So then the patient would be resistant to many viruses like EBV, adenovirus, CMV. And part of this, what we wanted to do is to prime the lymphatic system. So then what we decided is AML patients, well, it's not my protocol. I'm just explaining to you what Dr. Champlin and his team has done. The idea was AML, quite often they relapse in the marrow because we do not give them a myeloablative regimen. So then they thought, let's do a myeloablative regimen with 12 gray to the marrow and the spleen, while we're giving a lower dose to the lymphatic system, starting from all the lymph nodes in the neck down to the groin, to a dose of around 6 gray or less. Because in the mouse model, we found out that a dose of 6 gray or less is priming rather than killing. So then the differential use of it is myeloablate the marrow, prime the lymphatic system. That way you can engraft without fearing the disease is coming back your way, but then at the same time initiate a replication of the V2 cells and keeping them going because you're helping them with the T cell repertoire or the T cell diversification by increasing the T cell effectors and helping those memory cells that you already prepared them to keep dividing. Therefore, you avoid the engraftment and you myeloablate. And that's how we came with the idea of doing this protocol. So as a conclusion, I really want to say that there is a new horizon to the use of radiation. It is really effective at the low dose with no toxicity. And educating our radiation oncologists around the world is the next step that we are working very hard on it. And thank you. And I'm ready for the questions.
Thank you so much, Dr. Vathena Davaja. That was wonderful. So many new concepts. You convinced everybody about various activities and the research that we are doing. and you taught us extremely well.
Thank you.
I will request the audience to keep putting questions in the question box. Meanwhile, I'll request our faculty over here. I can see Dr. Velu Nair ready with a question.
Yes, sir. I'd like to congratulate you, madam, on an extraordinarily wonderful talk. I'm a hematologist. I'm a hematologist and a transplant physician, ex-army, now work in the civvy street. What really excited me is your immunostimulant effects of low-dose priming versus killing. My question is on CAR T cells. You talked about bridging. What would be the washout time when you want to bridge with RT, with your low-dose radiation, waiting for the CAR T cells is the first part of my only question on bridging. And number two is, can I extrapolate this to LO SCTs, wherein I have to wait some time? I can't find a donor. The donor search may take 2-3 months. And if I can prime the lymphatic system and the microenvironment and the T regulatory cells and get it in my favor, why not even try that as a trial? That would be great. So these are my two questions. I've been allowed one question each round by the moderator. So that's my question.
Okay, so for the first question, as you can see from 2017 until now, where we learn about the CAR T cell, we're still learning every single day. So at the beginning, when we start using the radiation, to be honest with you, we used it thinking that there is just a mass and it's growing, and they are manufacturing the cells. They need sometimes 3 to 4 weeks to manufacture. So they're telling us just to hold the tumor. And as we started doing this, we learned that no, it is not only just decreasing the tumor. We're doing way more than that, because quite often the cells would come earlier as we started manufacturing very quickly. And then you give sometimes 20% of the dose that you thought that you want to give, and it did the trick. So then what we learned is two things that are important, one for the radiation oncologist and one for the hematologist. You really want to do it in a way that it would not interfere with the apheresis nor with the lymphodepletion. Because if I'm doing it during this time, then I would kill the cells that you're trying to collect, or I would interfere with your lymphodepletion. At least there should be a good 2 to 3 days window between either the apheresis or the lymphodepletion. That's for the hematologist. For the radiation oncologist, what we learned is the following. When you give that low dose to disturb the microenvironment, the body or the microenvironment reset itself within 14 days. Now, this is not in human, this is in mice. And that's why we got those grants to study it in human. Does it take 14 days in human as compared to mice or not? But then to be on the safe side, if you want to give the radiation as a priming, it has to be within 14 days from the time you come with your either CAR T cell or immunotherapy. Example, I do the lymphodepletion, I do the apheresis, I start the radiation day minus 12, and I should finish it just before giving the CAR T cell. I cannot give the radiation day minus 20, because by the time 14 days has passed and I finished the radiation, then it will reset itself. And remember, that radiation is not 3-4 weeks like how we usually give radiation. It's only 3 to 4 days or 5 days and you're done. So therefore, it has to be finished within the 14 days. Yes. Otherwise, the microenvironment would reset itself. As for the question, why can't we reprime? I think this is the basis of all the research that we're trying to do right now. There is at least 7 or 8 protocols that between me and my colleagues are doing, all of them based on your idea, which is let's prime. The only issue is that we have to be able to really test the theory by getting blood testing, if we can get biopsies, to really prove that what I'm telling you in theory is actually happening in real life. But it's a fantastic idea.
You've seen that in the mantle cell lymphoma, you know, when you have the cell-free DNA, and if you see if you see a molecular response at that level, in a week or 2 weeks, you're there. So really speaking, it's very exciting. Thank you very much.
Absolutely. As a matter of fact, I convinced Dr. Champlin on 2 mantle cell lymphoma that instead of giving them 2 grade TBI, like how we usually give for the graft versus host disease, to give them 4 grade TBI, so it will work as a priming and it will address the whole body. And they went with it, actually.
Very exciting.
Great
Thank
idea.
you, sir. Thank you, Dr. Agarwal. Thank you.
Thank you.
Thank you. Anybody else would like to ask a question?
I had some questions that if Kalpish would
Dr.
I prepared some slides for it.
Okay.
Okay. So how are we going to do this?
Dr. Nehal desires to ask you something. Nehal, go ahead.
Very exciting presentation as always, and it's a treat to hear you. It's really great. I had 2 questions. One regarding how to convince our medical oncologists acknowledging the role of radiation with CAR-T. You have already elaborated on that. My second question was, how is the cardiac toxicity data evolving? Because in most of the presentations, the data that is highlighted on, even the data that comes to your mind or in a medical oncologist's mind, is a 20-year-old data. So how is the data evolving since the time we have started using these cardiac sparing radiotherapy planning, the change in contour, evaluation, better understanding of cardiac toxicity, and obviously with newer techniques like DIBH and all that?
Sure. Okay. Mr. Kalpish, can you share my presentation one more time and go to the end where I finished, if you don't mind? In the meantime, how to convince the medical oncologist. Yes, perfect. Yeah. Let me request control. So, my dear Dr. Nehal, the way you convince the medical oncologist is, so I used to be a medical oncologist in my, I started training as a medical oncologist. And when I went to MD Anderson, I did fellowship in medical oncology, and then I became a radiation oncologist. So I know exactly how the medical oncologist feels. First of all, as a medical oncologist, you have no concept of that radiation is a localized treatment. You always think of treatment as a systemic treatment. You give it through the vein, it goes everywhere. Second, in reality, the medical oncologists are right about the radiation oncologists. I'm not talking about you and me. I'm talking about in general. Radiation oncologists, those who goes into the field of radiation oncology, they are a bit technical, and the evolving their treatment and the conversation that goes between you and the disease and between you and the patient and how you change from one day to another, it's not very well established in the mind of a radiation oncologist, in a sense that I'm teaching residents, for example. They say, how much margin should I put on this? And I would say, I would never give you a margin. What do you mean a margin? It all depends where the tumor is. How did it present? How big is it? How close is it to the heart? What chemotherapy the patient got? When did he get the chemotherapy? How much adriamycin they got? When did they get it? And you could see that those who goes into the field of radiation oncology, they're always looking for the numbers. They want to memorize a recipe, go with the recipe. Just tell me what you want me to do, and I will do. And that's where the problem comes with when your medical oncologists are looking at you, saying, not you, but I mean, at the new generation or the generation of radiation oncologists, when they say, oh, I know what to do, and those are the numbers, and I'm going to follow it. They don't want somebody to do that. They want somebody to sit down with them and tell them, listen, I know your patient get adriamycin, and I know I'm only giving you 7% local control and 9% progression-free survival. I am aware of that. And I will make my toxicity similar to the benefit that I'm giving you. So it's not a war between you and the medical oncologist as much as what's in the patient's best interest. That's number one. Two, when you are a medical oncologist and you say the ISRT or the field I'm going to use is XYZ, but then what you use in head and neck and lung cancer is completely different than when you use in leukemia. Leukemia is everywhere. Multiple myeloma is everywhere. You shouldn't get stuck into saying, oh, under no condition I'm going to change my field. Like I give the exam, the oral exam to the residents in the United States. And sometimes I'm asking them a question honestly to help them. I'm not tricking them. And I say, listen, your field is next to the heart. And this patient got adriamycin, got so many treatments. Do you want to like change it? I said, nope, I will not change it. And I would say, look, the patient has her mother with her. She told you I'm a radiation oncologist and I really don't want this field to go to the heart of the patient. And I said, nope, I'm not changing it. So that mentality of not conversing with the disease and not knowing that cancer is not a number. Cancer has a personality like me and you. Today is one thing, tomorrow is another thing, right? And it also depends on the body that it is sitting on in it. So that's how you convince them, sitting with them, learning about their patients, learning about the chemotherapy that they took. That would all help you to be the best radiation oncologist. And eventually you could convince them. I convinced the medical oncologist at MD Anderson, the lymphoma folks. Those are the hardest human being under the sun. And I convinced them. I convinced Kantarjian, who is the guru of leukemia in the world. And I convinced him, not by anything, rather by telling him, I know where you're coming from. Now, I'm going to show you the data about adriamycin. I know that that's the data that everybody talks about, which is very old, and it's 40 years old. The proof is they're showing you that that's what happened with adriamycin 20 years later. That's what happened with radiation 20 years later. And I don't have... Mr. Kalpesh, can you move to the next slide for me, please? Ah, perfect. You see, this is the old data that we're talking about. We all know it. I still follow it to say that I'm going to do the worst case scenario, although this is the treatment of mantle cell lymphoma with cobalt therapy with very large dose, but I'm going to still follow it. You can go to the next slide. But I bring to their attention the following. This is a data that our friends, Dr. Mereldo is from Denmark, and she took all the ARTC data and looked at the question that you're always asked. Should I give 2 more cycles of chemotherapy or should I give radiation? And then you say the following. If you give every 50 milligram per meter square of adriamycin, which is 2 cycles AB of ABVD or 1 cycle of R-CHOP, is equivalent in cardiac toxicity to 5 gray of radiation. So then you make the math with them. Listen, if I give you a plan where 5 gray did not go to the heart, would you allow me to give and avoid the 2 cycles of chemotherapy? If they say yes, then go for it. I mean, they're not gonna argue with numbers or with showing them. Also, you show the medical oncologist your field. They cannot imagine it like you do. Sometimes they tell you, well, when you give the radiation, it goes everywhere. Don't blame them for saying that because you've never showed them your field. Every single patient that you treat for them, send them a screenshot, show them where did it go, how you avoided the heart, how you avoided the coronary vessels. It gets to a point that your medical oncologist sometimes would advise you and say, can you use proton on this? Can you use IMRT on this? Because you educated them like how you educate your residents. Okay, can you go, Mr. Kelpish, to the next one? This is a very important one, going to the numbers and the radiation oncologists, how they love numbers. The medical oncologists, excuse me, we're going to talk shop right now. The top part, it says mean heart dose is 12 gray. The bottom part said the mean heart dose is 12 gray. Mean is a number, statistics. The top part is killing the left ventricle and the left main artery. The bottom part is completely avoiding the left ventricle and the coronary vessel. Therefore, if I tell my medical oncologist, oh, don't worry, I gave the heart only a mean of 12 gray or less, without looking at the substructures. That's one question that somebody asked me. Do I go and look at the substructures of the heart? Oh, yes, I do. I look at the right ventricle, left ventricle, main coronary artery coming from the aorta, the LAD, the RCA, and I contour every single one of them, because when I look at the dose, I'm going to see exactly what that dose went. I'm not going to look at a mean. Mean is really, it's like you inherited from your rich uncle $1 million, and you say the mean number was $1 million, it went to 6 kids. You didn't say how much each kid's got, right? And it's the same thing right here. So therefore, it's meaningless to use those numbers, but rather to tell your medical oncologist, look, my left ventricle here is safe. My coronary vessels are safe. Okay, Mr. Kelpish, if you go to the last slide for this question. This is the UK Rapid that finally, and after so much debate between Dr. Illich and John Radford, they published this paper, which we are so thankful for them to publish it. And what it showed is the overall incidence of stroke and heart disease when you compare ABVD plus radiation. Mind you that its involved field is not involved site. So it's an older technique versus ABVD versus the general population. That's the general population. That's ABVD with the adriamycin, and that's how much dose radiation is adding. What it showed, one to our benefit and one to our dismay, that the slightest dose of radiation, as you can see here, between 1 and 5, the curve starts going up against you. When you get to 5 to 10 gray, look at the curve. This is a mean dose. And if you look at the mean dose, it's not going to be beneficial. But then what is telling us, and what we should do as radiation oncologists, is stop giving radiation next to the heart, period. You do not need to do so. If there is only one node next to the heart, leave it to chemotherapy to work on it. Only give it to the bulky area. Only give it to the stem of the cells, because you can never get to a point to avoid the heart like they're asking you to do here. If you want to keep a role in this disease, then once and for all, you need to understand that this is not squamous cell of the head and neck, and this is not prostate cancer. I think I answered you. And there was a question about deep inspiration, breath hold. If Mr. Kelpish can go to the next one. Oh, this was the mesenteric node question. So I was asked, how do you address a mesenteric node question? If you like, I published a mini atlas for radiation oncologists in the Red Journal, and I would be more than happy to send you the link to Dr. Agarwal when we're done for the radiation oncologist. What it does, it takes you step by step for radiation oncologists on how to treat every single site, from the stomach to the groin to the mesenteric, chest, etc. And what it shows here is, let's say you have a disease in this area, and that's how it presented. And I was talking about how lymphoma is like a balloon and it deflates. So this is the disease on the PET, this is the disease on the CT, and that's post-chemotherapy. Now, look at where my target is. That's my target in red, that's my target in red, and that's my target. I didn't make my target as big as the tumor before, because lymphoma does not have fingers to invade the neighboring structures. It's literally inflate and deflate, even if it had fingers. That's why chemotherapy works. Just imagine that most medical oncologists in Europe, they give the chemo without even considering radiation. So if you want to still give radiation, you need to convince them that you cure patients in 85%. If you want me to add to your cure 10%, then I'm going to give you zero toxicity. Because otherwise they're going to tell you, no, I'm fine with the 85%. If the patient recurs, then I'll send them to transplant. You cannot argue with them that, oh, well, transplant is toxic. Well, of course, transplant is toxic. But if you give toxicity to 85% because you're not careful about their kidneys, their heart, their coronary vessels, their spleen, their pancreas, then it's going to show up. These patients live for a long time. They're going to come back and hunt you with the toxicity that you caused. I do breath hold on all of these. Why? Because I want to avoid those kidneys. I do not use the stomach cancer constraints or pancreatic constraints or any of the solid tumor constraints. These kidneys are like jewels. They're going to see so many chemotherapy in the future if this patient would recur. And even if the patient doesn't recur, this patient is going to live for 30 years and they're going to end up with chronic kidney disease if you're not careful. Mr. Kalpish, let's go to the following one. Okay, that's how it looks like on coronal. You see, if I had to follow the tumor, my field would have been so big. No, I'm just going where the stem of the disease used to be, up and down. But you see, the kidneys, they were pushed outside when the tumor was here, because look at the distance between the aorta and the kidney. It was very big. And then here, the kidney came back. So if I would have included the pre-chemo volume, I would have got half of the kidney inside my field, which I shouldn't. Mr. Kalpish, let's go to the next one. And that's how I do it. The fields comes from anterior, and look at that beauty. The 5 gray line completely off the kidneys on this side and on that side. And look at my kidneys. They are right there getting very little dose. Yes, you could tell me that, oh, I can give the kidney 15 gray and nothing is going to happen. Of course, nothing is going to happen if you have stomach cancer and you're going to die in 2 years, because by the time something is going to happen, the patient would be dead. But then in lymphoma, when you give it, the patient is going to come back and hunt you 15 years later. Mr. Kalpish, if you can go to the next one. Oh, breath hold. Somebody asked me, why not ABC? Because with breath hold, I don't mean only to fix the organs in where they are. I mean to create a big differential between the target, which is the mediastinum, and the lung. Make the lung very big. So 5% of a lung, which is 5 liters, is not the same thing as 5% of a lung, which is 2 liters. The amount of it is going to be bigger. So that's why ABC now the ABC, that is a controlled breathing where you know how much you're going to put in and pump it in the body. Yes, that would be good. But the one that you're just trying to hold breath without filling the lungs, then I'm not sure that I like it that much. Mr. Kalpish, if you can go to the next one. And somebody asked TBI, TLI, and TMI. TBI, as you can see, this is the old technique that we use. That's the head of the machine. The patient is sitting there, and you flash the body through and through with the dose. You only block some of the kidneys to less than 10 gray because that's the dose associated with pneumonitis. We currently block the kidneys at MD Anderson for the regular TBI only for AML. We do not block it for ALL because ALL has the capability of relapsing in extramedullary site like kidneys. Now, TMI, I like to use it at this point only for AML, not for ALL, because as you can see, total marrow irradiation will avoid the brain, will avoid the kidneys, which is something I have an interest in not avoiding with TBI for ALL because there is a risk of relapse there. This is a debatable subject between me and the radiation oncologist at City of Hope, who's done 500 TMI with the City of Hope Transplant Center. But I still insist that at this point, before moving to using TMI and ALL, we need to think about it. Next, Mr. Kalpish. This is total lymphoid irradiation. I personally don't use it that much, but in Memorial Sloan Kettering, they use it, and I'll tell you when they use it. So the TLI is you chase all the lymph nodes in the neck, axilla, in the mediastinum all the way down, in the para-aortic, common iliac, all the way down to the groin, and you give them a dose of radiation. I used it, and I'll tell you why I used it in a second, but in Memorial Sloan Kettering, they use it for Hodgkin, which makes perfect sense because Hodgkin is a disease in the lymph nodes, and they do it before moving into transplant, and they swear by it. And they have excellent results with it. Now, why did I use it? This is a patient with mycosis fungoides that I gave him total skin prior to go into allogeneic transplant. He got a haploidentical and went into transplant, engrafted, but he did not develop any graft versus disease or any graft versus host disease. So then he's relapsing right now with lymph nodes all over. What I decided to do is, while I'm treating his lymph nodes, I'm going to treat him to a priming dose and come immediately after that with either romidepsin or brentuximab, both of them to get benefit from the priming of my dose to only 12 gray to the total lymphoid irradiation. So as you can see, clinically, we are using that dose of radiation with priming prior to immunotherapy, like you're seeing there. I think this is for Dr. Nihal to be happy with this slide. This is a pediatric database that is in children that never had any radiation. They only had chemotherapy and they developed breast second malignancy. So if there is a heated debate between you and your friends in medical oncology and you want to show them this, feel free. My slides are with Mr. Kalpish, so he can share it with you. I think that's it. We're not gonna anymore poke the bear. We're making friendship with the medical oncologist, so we're not gonna poke the bear anymore. Any more questions?
Yeah, Dr. Akanksha has a question.
Hello, ma'am. Thank you so much for the informative talk. So I have two simple questions to you. One is, what is the lowest age or the pediatric age where you would consider radiation to be a contraindication? And second is that in patients of Hodgkin's lymphoma, which have previously received radiation, if they relapse, is there a role of giving radiation again to maybe the same areas there is an involvement at the time of relapse?
Okay, so unfortunately, I don't treat pediatric patients. I treat them only until the age of 15 because I overlap between me and the pediatric group, so I can't tell you about that. Having said that, I do get consulted on lymphoma patients, and quite often is for craniospinal irradiation that we treat them. I know that giving them craniospinal will affect their growth and has a lot of side effects, but quite often they are at a very desperate situation, so we go ahead and treat it. So as for in Hodgkin, do we treat again? We do treat again, and we use proton in these cases because it will give us the ability to treat without exiting with the dose in the core that probably has maximized or in any other structures. So this is when we use proton. Have I used it with IMRT? Yes, I did. It takes a long time of planning and making a composite plan. You're quite often limited with the dose, but the reality is, and I've had this conversation with Dr. Hutchins from Princess Margaret, he's a big believer in the fact that for any disease relapse, we shouldn't use more than 30 gray in Hodgkin. He swears by it, and he says that in many of his patients that relapse, he never used more than 30 gray. Therefore, if you have a patient that you want to retreat, you can treat to 30 gray, and I'm sure one way or another you can get away with it.
Thank you so much.
Thank you, Dr. Deepali, and then Dr. Deepanjan.
Thank you, ma'am, for such nice explanation. It has covered all the questions. One thing I want to ask, post-COVID, do you find any changes for DIBH practice?
So post-COVID, if you're saying that if they have shortness of breath, you mean?
Yes, ma'am.
That's a very good question. A few weeks ago, we had a patient that we couldn't do the breath hold. So what I did is I asked them not to take a deep breath, but rather to hold it as much as they can. And even if they hold it for 5-6 seconds and then they relax, and 5-6 seconds and they relax, I thought it should be okay, because even when you're using IMRT, if they drop their breath, the machine would stop the treatment, so it should be safe. So if you run into this problem, I think you can do multiple breath holds to simulate, and then eventually multiple breath holds for them to stay on the table.
Thank you, ma'am.
Okay, Dr. Deepanjan.
Madam, my question is regarding the use of TBI for myeloablative conditioning as conditioning. So traditionally, people have been using cyclophosphamide TBI as myeloablative for ALL conditioning. However, it's limited by its extensive toxicity, mucositis. So for elderly or less fit patients, we have been using busulfan cyclophosphamide. Now there have been interest with flu trio TBI protocol, especially the Seattle protocol. So in which a low dose TBI is being used. So how do you see the use of low dose TBI as conditioning prior to transplant? And so especially for elderly or less fit patients. And do you think that it can replace the busi, so which again is limited by mucositis?
Mm-hmm. So the City of Hope, what they're using is total marrow irradiation, which is what I showed you. And particularly when we're planning these patients, we completely avoid the mouth, the throat, and if we can, the esophagus, to decrease the amount of mucositis that we use. In that case, you really don't need to drop the dose of TBI. In general, I divide the TBI into two groups. The one that you use a low dose TBI, 2 gray or 4 gray, just to invert the T4 helper T8 suppressor ratio and to help you with the graft versus host disease. That's 2 gray, 3 gray, or 4 gray. That's what we use. The other one that we use, a myeloablative one, we use, for example, 8 gray for a scleroderma, for autologous, but that's the lowest dose that we use only for scleroderma. But whenever we are using a myeloablative dose, then we go to the equivalence of 12 gray. We did two things to avoid the mucositis that you're talking about. The first one is we started to use right now total marrow irradiation to avoid mouth, as I said, the bowels, etc., with a lower dose. And the second thing we did is to use proton, because the proton, what it does not exit through the body. It just stays next to the spine. Ideally, and from a physics point of view, it is true that when you use proton, it does not exit through the mucositis. But what we found out in a paper that we published, and I can share it with you at the end and send an email to Mr. Kalpish to share it with you, is that when we compared all the one that we did proton, for example, craniospinal irradiation with proton, which is also exit through the mouth and you end up with mucositis, versus craniospinal with photon, we didn't find a difference between the two. So when it comes to the TBI, the only solution really is to use total marrow irradiation. I am not sure that the City of Hope, from my understanding with how they deal with it, and we had a meeting with them like a month ago, is that they're trying actually to intensify the dose of TBI, and they went all the way up to 20 gray, and they published the paper where it says 20 gray TMI, which is total marrow irradiation, is safe in their mind. I'm not sure that the group at MD Anderson are interested in this yet, because I think that once you ablate the marrow, you ablate it. Giving more, it will really end up killing the fat cells. And I think that the microenvironment where the engrafted cells comes to live in, it's like you invited somebody to rent your house and you destroyed everything, is unlivable for them. That's how I think about it. So if you give so much TBI to a point that to destroy the fat cells or the fibrotic structure where the stem cells survive, I'm not sure that the engraftment is going to be successful. Having said that, their paper says the opposite. It does say that even if you go up to 20 gray with total marrow irradiation, it should be safe. But my point is, if it was such a great idea, then we all would have known about it and start using it, right? So 12 gray, it makes sense. Less than that, as I said, I don't think it makes sense. There are other ways to avoid the mucositis as we discussed.
Thank you.
I hope that I answered your question.
Yes, ma'am.
Dr. Akanksha, you can read your question.
There is a question, is there a difference in dose efficacy and side effects while delivering 2 gray times 3 days dosing, 2 gray times 6 days TBI? Absolutely. So we went through this a lot with our radiobiologist and with the City of Hope in particular. They had an excellent radiobiologist. I forgot his name actually, but what he mentioned is that the dose that we use with TMI, it would have been better if we did the 2 gray BID. But here's the problem with total marrow irradiation. Every time you do total marrow irradiation, instead of the patient being on the table for 20 minutes for a regular TBI, they're going to be on the table for 1 hour and 50 minutes. And if you do it twice a day, then the patient is going to be on the table for 4 hours. 2 problems with that. One, who is the patient who's going to sit on the table for 4 hours without moving? And second, as you can see in the United States, money is important. If I tell my chair that I'm going to put my patient on the table for 4 hours and occupy time on the table, I don't think they will be happy with me because it's not that I'm going to earn more money. So logistically also is a problem. But to answer your question, yes, it is more effective. And also the monitoring unit that you're pumping makes more sense because we try to go faster. We said 300 monitoring unit, and then City of Hope said they go to 500 and 600 and they never had trouble. We hesitated at the beginning, but now what we do is we do everything to 500 except when we're doing the chest to avoid the long dose to going to 600, we do it to 300. Do we know what we're doing? Do we have a study? No, we're just scared and we're doing it step by step, not to run into trouble. Hopefully in the future we can publish and answer your question in a more scientific way.
Yes, ma'am, because especially in pediatric patients, giving them the sedation twice a day, it becomes very difficult, and many times it's difficult to sedate them also. So that's why I asked. Okay, thank you so much.
No problem.
Thank you. Nishad?
Ma'am, in patients having cord compression because of myeloma bone disease, how do you decide about decompression versus radiation?
Okay, so we always consult the neurosurgeon. I have to tell you, 9 out of 10 times the neurosurgeon said, I'm not taking them to OR. Quite often, it's hard to put the hardware in their spine because they are extremely weak, and once they put the hardware, it might actually break there. So most of the time, we end up either with a kyphoplasty or with the radiation. Because we are giving a super low dose of radiation, we depend on the fact that if you consider the vertebral body like this, and you consider the myeloma inside it as a soft, gooey area, what you're hoping for is you give the radiation, you get rid of the soft, gooey area, and wherever it's compressing the cord, and then after that, hopefully the vertebral body would not compress and you would end up with building solid calcium in that area by the osteoblast, and that's a happy ending. It's not all the time a happy ending. Sometimes what happens is the vertebral body would collapse, anyway, cause the pain anyway, you end up giving the radiation, and it might relieve the pain a bit from the gooey myeloma that went outside and took care of it. But then the compression fracture, it will leave them with pain for a long time. They cannot do the kyphoplasty because it would leak into the spine. So it will be impossible for them to do the kyphoplasty. The neurosurgeon doesn't want to touch them because then they have to put the hardware that maybe their body cannot take the hardware. So you end up biting the bullet and saying that let's wait on them for 5-6 weeks until the vertebral body would remodel, their body shape will remodel. And that's why, as you probably you know better than me, they end up with those severe shortening of the spine, severe kyphosis that you can never help them with. It's a very difficult situation, to be honest with you. Quite often we joke among ourselves that people think that treating a myeloma patient is the easiest thing for a radiation oncologist, but then quite often we discuss it for hours between us, the medical oncologist and the neurosurgeon, because every single one of them is a challenge.
Thank you, Dr. Nishat.
Says my question is how PET scan has changed the practice of radiation oncology and hematological treatment as we use consolidation to bulky site, even if patient in CR post chemotherapy. Yes, it did change. And I'm going to tell you on a personal level and as a physician. On a personal level, it used to cause me a lot of anxiety because I would think, oh my God, now the PET scan came, there is no role for me as a radiation oncologist. But it doesn't cause an anxiety anymore because I discovered that radiation can be used as a priming effect. And I found now I have a role in mantle cell lymphoma, in leukemia, in diffuse large B-cell lymphoma, relapsed refractory. So I don't have the same anxiety. Having said that, the key in these cases is that as a radiation oncologist to calm down and say, okay, if you don't want to use consolidation, that's fine. As long as we are on the same page that I can avoid relapse, for example, even if the PET scan is negative, but then I have a mass, paraspinal mass. Why should you want to deal with the fact that this paraspinal mass can come back and haunt you in that area? If I give a very small dose of radiation. As I said, in diffuse large B-cell lymphoma, the dose right now is 20 gray. In the future is going to become 20 gray. That's a very small dose, and you can do it safely. In Hodgkin lymphoma, same thing. You're using, if you have an early favorable German Hodgkin criteria, you can give 20 gray. If you have even early unfavorable, you can give 30 gray. So it is true that we can do without the radiation. Absolutely. How much would you lose? Maybe 7% in the overall, in the progression-free survival. Therefore, the key is to always say, I'll give you worth your money, basically, which is here, worth your toxicity. And you can still use it and be reasonable. If a patient, after 2 cycles of chemotherapy, they went into remission and they have a small node here that it is not bulky, and you give them a total of 4 cycles as per the LISA, I'm not going to chase anybody to give it radiation because it's unreasonable. But if something else next to a critical organ, then I might. Again, the cancer is a living and breathing disease. You negotiate with it. And as you negotiate with the doctor taking care of it, there are no rules that you go by that are black and white.
Thank you. Any other question, please? If none, then thank you very much, Dr. Vaidhana.
Thank you so much for inviting me. Always fun, great questions. You have the best physicians ever. I brag about you to everybody, especially to your colleagues from India and MD Anderson. I tell them that those people are so smart. You left the smartest people in India and you came here.
Thank you for those compliments. And thanks to the faculty here for making this so lively. Thanks to Kalpesh and the team for organizing this and looking after this, which was totally flawless, and our sponsors, NATCO. for doing a great job in supporting
Absolutely. Thank you.
Thank you, and good night, everybody in India.
Bye-bye. Thank you so much.
Thank you. Good night for a lovely talk. Thank you.
Bye-bye.
Bye.
Thank you.
Bye. Thank you, Dr. Thank you, Dr.
No
Agarwal.
problem. Anytime. You can get my slides from